You had such a vast career. You've met so many of our great psychotherapy figures. I know that in the first 10 years of your career, they were spent in mainly psychiatric departments.
Yes.
And since then, you've published many articles in both medical journals and psychological journals. How do you feel that this dialogue with the medical model, did it add to your sensibilities as a psychotherapy researcher?
Well, that's a good question, actually. And I think the first 10 years of my career, which was spent really right in the middle of hospitals, very busy hospitals with a lot of patients with very severe psychopathology problems. I think it was really added a lot of breadth and depth to my experience. I ran psychology training programs, internships we call them, in both settings where I was, the last one being Brown University, Rhode Island, at the medical school. And we actually had the interns be on call to the emergency room so that they had experience in seeing the most acutely severe patients and could make decisions on whether to admit them to the hospital or send them home, even though they might be threatening harm to themselves or somebody. So it seemed to me it was very important as a psychologist, and I think I had the advantage of becoming very confident in my, first of all, knowledge of the full range of psychopathology and in my ability to really deal with the variety of issues rather than punting or so to speak, calling the more senior psychiatrist to come in if the problem got severe. I think that's kind of an important quality for many psychologists to have, and I think it benefited me. And also, so I never really, we always worked very well with our psychiatric colleagues in these settings because we were pursuing, we did our clinical work, but we were pursuing research goals. We worked very collaboratively in that regard. Sometimes the grants were on new psychological treatments. Sometimes they were on combination of comparing medications to psychological treatments and their combination. And I think everybody brought something to the table that was useful. So, we never really had a strong clash of fundamental epistemologies or views of the world or models from which we worked. We pretty much worked from a kind of empirical model by then.
This is very interesting what you're saying, because in many mainstream psychotherapy circles, this integration that you seamlessly do of the neurobiological medical model, it's suspicious for many of our psychotherapy colleagues. Why? I know this is something that's been going on for decades now, but seeing it from a 2016 perspective, do you feel this suspicion towards the medical model? It's a historical artifact. Do you feel, are there any good reasons for it? Is it mainly competitiveness? What do you think?
Yeah, I think it's overblown. I think in the early days there were a number of components to it. The medical model is a very nebulous term, and I found when discussing it with my colleagues that many of them mean different things, one from the other. In some cases they mean simply a focus on treatment with drugs or more organic treatments, as opposed to more psychological treatments. But there are many psychiatrists who do psychotherapy and who actually prefer that model, particularly in Europe. In the States, many psychiatrists have been forced into just giving medications because of economics. But so, I mean, that's kind of and there's evidence that I happen to believe that the psychological interventions that we've all developed and worked on and are the most effective in the long run. They have evidence for they're just as effective as drugs in the short run for the wide variety of conditions, and they're more enduring. There's less relapse. And there's now evidence, that the medications, that there is the bodily systems, the physiological systems adapt in some ways to the medication that are not always in the patient's best interest. In other words, there's some untoward long-term effects that I think we're just discovering. Nevertheless, there's some evidence that medications obviously can be very useful, particularly in individuals with acute psychotic conditions, but integrating the psychological treatments with the medications, we know will double the efficacy, increase survival time to the next episode. And so it always seemed to me to be kind of something we should be working to look at, what's in the best interest of the patient. What's really going to give the most help to the patient. And let's look at everything that has, based on good theory, a reasonable chance of working. And furthermore, I think we've known now for decades that the problems we treat, various presentations of psychopathology, are really organized systemically in systems, and that you can intervene at different points in the system and affect the whole system. So, we used to assume, and this is where some of the medical model came from, we used to assume that you could intervene at the level of the mind, and the mind is going to do its thing. Or you can intervene at the level of the brainstem by, changing certain cell receptor physiology, and that would do things. We now know that when we do our psychological interventions, we're changing brain function and also actually brain structure in terms of, let's say, cell receptor physiology. In addition to attitudes, behaviors, and emotions. And similarly, when some medications are effective, obviously it's changing not only neurobiological variables, but also thoughts, feelings, and behaviors. The question is, which one, what's the best mix and match, and for both short and long-term effects, it seems to me. So, that kind of definition of the medical model sort of falls down. The other definition is that, well, you're treating symptoms and not underlying causes. But, that doesn't hold up. If you look at the totality of medical interventions, in some cases, the causes have been discovered, and there are treatments that have been developed for, certain, let's say, bacterial infections or something that lead to a variety of symptoms. In other cases, we're doing palliative care, and we do that both in, mental health and physical health. We're obviously trying to do more than just treat patients symptomatically, but on the other hand, we are looking for treatments that are going to have the longest term effects. We don't know the cause of everything. We don't know the etiology of everything. We're working hard to discover it. I think there's more collaboration and cooperation these days among, let's say, the neuroscientists and the psychopathologists. There was just a special issue that you may have seen of behavior research and therapy on the neuroscience of psychological treatments, and I happened to write a commentary on it. And I think given that we're having major effects on brain function, that we need to, look at that body of evidence. And indeed, when we do, as people like 𝗵cie𝘀𝘁𝗁 and others have done, we find that there are some hints there on how we can improve our psychological treatments.
It's been interesting to see how effective neuroscience has been showing up more in your work also.
And I think, again, that reflects the times. But I think it's also another kind of nail in the coffin of this medical model versus all the other models that have proposed. I think you have to have an integrated, multidimensional kind of approach if we're ever going to make progress in solving these problems and not pit one model against the other. That's my view anyway.
There's actually one book you wrote. I think it's going to its 8th edition now in next year, the Abnormal Psychology one.
Yes.
And the subtitle is an integrated approach.
That's right. That's we wrote the first edition of that book maybe 22 or 23 years ago. And at that time we proposed that, we're going to have to take this integrative approach to most fully understand the phenomenon we deal with. But at that time it was very, very radical, and our publishers would say, "Oh my God,
what are you doing?"
Will the instructors actually buy this book? Because they were used to teaching by the old, we call it the Chinese menu approach. They say, here's the psychoanalytic view, here's the behavioral view, here's the biological, here's the Rogerian view, of, let's say, anxiety or something. And here's the psychoanalytic treatment, in a separate chapter. Here's the behavioral treatment, here's the cognitive treatment, here's the Rogerian treatment, here's the drug treatment. So, and none of these things were integrated. It was just like, well, choose one from column A, one from column B. Where's the student? How's the student going to do? So we thought it was, time to really begin integrating the knowledge we did have.
Yeah, you're touching on an important topic because many psychology students, including here in Europe and in Portugal, it's very disorienting sometimes with all the schools of therapy to kind of get a fix of where to go. One interesting thing, distinction maybe we can make, is that we talk here about an integrative approach, but it is slightly different from what some people might know from psychotherapy integration. You're not just talking about integrating different schools. You're talking about evidence-based integration from different fields of study and of science.
Yes, So it's, I'm a member of 𝗵cie, and obviously I think that organization serves a valuable function. We're looking at the integration, but I think it needs to go well beyond that. And we need to integrate, fundamental knowledge that's relevant to what we're doing from all fields of inquiry, as we just talked about, including neuroscience.
There are still some different views, different readings of the psychotherapy literature. And I already had the chance to interview Dr. 𝗔𝗹𝗲𝗅 for what you can say the common factors, contextual model. So now I can't not ask you for your own take on some of these issues. So if you don't mind, I would like to play devil's advocate and ask you about a number of topics.
Sure.
And one of them, first up, is the 𝗔𝗹𝗲𝗅 verdict. As you know, this conclusion that most major schools of therapy seem to have equal outcomes for most major disorders.
Right.
What would be your answer to that?
Okay. Well, that's been, it's been a very interesting point of contention over the decades. And Bruce and I have known Bruce for many decades, and we've had some interesting debates on the topic. And he's always a gentleman and a scholar, as I've told him about it. So he comes at it from a very scholarly point of view. And so these debates can go on for hours, point by point and point. But my general take on it is that, of course, what the so-called common factors are part of any effective treatment, whether it be, by the way, medical or psychotherapy. You know, it's not just psychotherapy; it's medical treatment. Very powerful data that we have written about ourselves, particularly on the effects of, like say, patient expectancies.
Yeah.
In fact, one of my points I've been making lately in my lectures is that I think psychotherapists have been underutilizing the power of some of these so-called common factors. So there's the notion that many psychotherapists have the notion it's very important to form an alliance. Everybody believes that. Everybody believes that. Obviously, you have to establish some kind of a relationship with the patient for them to properly receive the treatments you're giving them, whether it's a pill, or a psychological procedure. But then psychotherapists often stop and they say, well, no, we'll just see where it goes.
Yeah.
This relationship. Well, the fact is, we know that positive expectancies, when set up properly, are going to have very powerful influences on cognitions and behavior, and for that matter, neurobiology. Why not actively incorporate that into treatment? Some people, particularly those of our colleagues who are studying placebo treatments very closely, and we have some people here in Boston, such as 𝗔𝗹𝗲𝘅, right down the street actually, they have said, there are some actual things therapists can do to maximize expectancies. We can show them the data from, about patients, the percentage of patients who really benefited in the past from one treatment or another. We can show them videos of patients talking about their treatments. We can give them some, basically operationalize expectancies and make it part of our intervention. Make it another module, if you like, in our treatment. There's too many therapists just sort of wait for it to happen, and hope it happens. And it may or may not.
What you're saying seems to connect with the emphasis you gave on later versions of your transdiagnostic protocol on motivational, let's call it motivational engagement interviewing. But at a certain point you put more of that. Was it?
We did. Yeah. We discovered, again, the data showed very clearly, data from people like 𝗵cie𝘀𝘁 and 𝗵cie𝘀𝘁 and others, that rather than just hoping the patients were motivated enough, and measuring them on the readiness for change scale, let's make them motivated. Let's intervene on that with a module, and that module, of course, is motivational enhancement therapy. It's amazing that it took us until maybe 10 or 15 years ago to discover that we should be actively intervening on that. Initially, of course, we just thought it was for the addictions, for behaviors that were pleasurable but undesirable. So that conflict. But we now discovered that no, it's also very important to do it for emotional disorders, even though they are unpleasant. Still, people need motivations to engage them directly and to overcome them. So we need these common factors. We research them often. We've established particularly expectancies and the alliance. But we think the data are overwhelmingly positive on the impact of our psychological procedures. So, and this is, I think where, in my view, people misunderstand what 𝗔𝗹𝗲𝘅 is saying, and others who also, I think, misrepresent what he says. But there's no therapist that I know of in the world who would take someone sitting in front of them who happens to be suffering from, say, bipolar disorder on the one hand, or a specific phobia on the other, and treat them the same way, assuming the common factors will do all the work. As long as you form a good relationship with them and, you know, get them expecting they're going to get better, it doesn't matter what you do. Well, anybody, including 𝗔𝗯𝗃𝗁, is going to treat somebody with a specific phobia with exposure. We know a lot about exposure. We know why it works. We know the brain mechanisms now underlying, you know, successful exposure. We know that it's not simply habituation, it's the creation of new memories, the work from cognitive science, you know, overlaying the old memories. We know it's effective from decades of research. We know why it's effective. We're now learning how we can enhance its effectiveness. And so to assume, you know, that there's no evidence that it's effective is just naive, in my view. And every major policy-making body in the world now, when you go to, let's say, the Veterans Administration healthcare system in the States, you go to the National Health Service in the UK, and look at other health services in developed countries, they have all had independent experts evaluate the totality of the data and have found that there are some interventions that work better than others in the context of a good therapeutic relationship and expectancies and all that. And they have designated them first-line treatments. And so there's nobody, you know, it makes for a good debate. But in the policy, the healthcare policy world, nobody believes it. That interventions make no difference, so they all work the same. Nor is it what 𝗔𝗯𝗃𝗁 says. What 𝗔𝗯𝗃𝗁, the sophisticated point he's making, is that you have to use an active treatment. Okay, he admits that. It has to be a very credible intervention to the patient. You know, and he admits that. It has to be, you know, something where the patient's actually changing his or her behavior. And he admits that. And he excludes everything else. He says if you have all those conditions, then these treatments tend to work in similar ways.
𝗔𝗯𝗃𝗁 conditions, the myth, the ritual.
Yeah, in the ritual. But if you have all those conditions, you then have, you know, basically you have to, it's narrowed down to one of the active treatments. So, you know, 𝗔𝗯𝗃𝗁, when he sees somebody with a specific phobia, well, you obviously use exposure treatments. So I think it's it's been kind of a red herring. It makes for great debates. I think the unfortunate side of it is that a lot of therapists, with their confirmation bias that we all have, you know, there's not one therapist in the States who thinks they're below average. You know, everybody thinks they're an above average therapist. We know that's not true. Lambert, you know, has done some great work on that. And, you know, when he gives them feedback, what do? They change their behavior. But he hasn't taken the next step and says, what specifically, how are they changing their behavior? Well, I think they're now using evidence-based treatments. And so, you know, I think the whole debate, in my view, has been kind of a red herring.
This is very helpful because you're kind of dispelling some myths about this dichotomous way of viewing contextual and medical model. Another thing that's usually quoted, maybe you can help us to sort this out also, is this idea that the outcome is more predicted by the common factors than by specific techniques, which is also something that's said a lot in a way.
Yeah, you know, the problem with that, you know, I've seen some of those, and we have, there's countless meta-analyses, you know, showing that certain techniques, particularly exposure techniques and cognitive techniques, even some, you know, in the case of motivational interviewing, some Rogerian techniques, countless meta-analyses showing that, you know, certain techniques are better than others. And this is what, and some of them better than drugs, you know, or some worse than drugs. And countless techniques showing differences in approaches. And this is what the policy-making bodies rely on. So then you get these kind of post hoc correlational, you know, analyses that from some people. And they say, oh, the common factors, you know, expectancies and things, reliance, account for a greater percentage of the variance. Often it's a very tiny percentage because these, the statistics are, statistical analyses are very tricky. There's often restricted ranges in the outcome. There's a lot of things that throw off these statistics. But you get these arcane, esoteric arguments among the people with the various statistical expertise. Mm-hmm. Some saying, well, you didn't account for this, you didn't account for that fact, you shouldn't have done this. And the people end up disagreeing. I don't think these post hoc, weak correlational analyses, of broadly, large numbers of studies of different therapies really tell us much of anything. Mm-hmm. Look directly at the effects of the interventions. Mm-hmm. Whether it's in, and I prefer a more idiographic approach, mm-hmm. Focus on the individual. Look directly at the effects. Dismantle the treatments. Look at the active ingredients, as we have with exposure and extinction-based procedures. Find out why it works. Look in the brain. See what accounts for it working. The fact is, no one pays any attention to these studies anymore from the policy-making point of view, showing that somehow, all treatments are the same. It does give permission to therapists, and I think this is the unfortunate side of it, who might otherwise be motivated to, let's say, through continuing education or whatever, become familiar with the most effective new procedures. It gives permission to them to just sort of keep going along the same route. Mm-hmm. And people have studied this, they've looked at.
So it could become an ethical problem, you mean?
Yeah. I think that I'm not questioning for 1 minute, the ethics of motivation of people like Bruce Walpole, mm-hmm. who's, again, I think a very scholarly individual. But, I think it does have the unfortunate effect of holding back the best care that our patients can receive.
Yeah. You mentioned something very interesting about your work, the ideographic side, because there is something interesting that comes up when people think of evidence-based interventions. They sometimes have this idea associated with it, with manualized treatments, rigid interventions. And I read your work and you have single-case experimental designs and this focus on the individual. So could you help also clear up a little this balance you do between structure and flexibility in an evidence space?
Yeah, and I think that's another, I'm glad you brought that up, because I think it's another misconception, at the very least, mm-hmm. Of a lot of the work that's going on. Obviously, one individual differs from the other. Right now, we're working, under the sort of general notion of categorical classification. So we say somebody has a phobia, somebody has bipolar, somebody has panic disorder, depression, etc. And that's a convenient way for clinicians and the whole field to communicate. But nobody believes that that's the best way to classify psychopathology. Everybody agrees we're going to have to go to a more dimensional system. And individuals are going to differ on various aspects of the dimensions of psychopathology. And it's important that we, I think, ascertain the individual characteristics. And so we're developing some new assessment procedures, at least for people with emotional disorders, that arrays people on 6 or 8 different dimensions, including temperament, but also types of avoidance behavior, and types of emotional experience, and triggers for that experience. And when you do that, then it lends itself to really flexibly adapting our protocols to each individual patient by giving them, let's say, a better dose of addressing where their real deficits lay. And I think that's going to be the future of our profession. So I've been very critical of our own research methods that take these very nomothetic approaches that average in hundreds of patients and tell us, on the average, treatment A is better than treatment B for these hundreds of patients. But whereas the clinician is looking for information, what about the patient sitting right in front of me?
Yeah.
You know, I mean, do I take the average treatment or do I? And naturally, every clinician needs to flexibly adjust. We're hoping to, with our latest research, provide better guidance on that.
Yeah. So more like steps or tasks, but of course you're not ordering like on session 1 we do this, on session 2 we do another.
Right. Yeah. Well, I mean, there's some structure, obviously, to the treatment, and we know that it's best if the structure is followed. But there's also the notion that it has to be adapted by the therapist, who's, after all, right there on the front lines, you know, to the person sitting in front of them. So, of course, it has to be flexible. Where you get this notion of inflexibility is among people who have freshly learned some of the protocols, and they have a book in front of them that sets out the procedures. And typically we find they haven't had the experience to really, administer it to a patient. So they end up like reading it, being very inflexible in how they administer it. The same thing with diagnoses. And new therapists, newly trained people often reify, we call it, reify these diagnoses. Say this is a real category. When that's meant also to be just a guide, a flexible guide to describing the patient. So,
one other thing important in your work, of course, was the development of the unified protocol, a transdiagnostic approach. I think we don't have to go a lot into that since, of course, many people have already heard about it. And I would still just like to connect this with a recent interest of yours, some great articles you've done on neuroticism. And this particular concept, it's so old, but you're giving it the 21st century take on it. Would you mind?
Yeah, ironically. Yeah.
Ironically, yeah. Could you tell us a little bit? Because just to state this, so you recently made the case for shifting the focus of intervention to a higher order dimension of personality.
Yeah.
We could call this the neuroticism. Can you tell us first where this emphasis came from, recent emphasis?
Yeah. Well, it actually, it is, I'm well aware of the irony also. When I was, many decades ago, when I was a young fellow like you, and or even younger in training, everything was neuroticism and neuroses. And, anybody who did not was not blatantly psychotic fell in the general category of neuroses, and of course there was an explanation for the etiology of neuroses.
Some borderlines.
It was almost all, back in those decades, psychoanalytic thinking. And there was no neurobiology, there was no biological conceptions, or no behavioral conceptions. So, and then of course that the field changed, and by 1980 the term neurosis had disappeared from the nomenclature, from the classification systems, or at least mostly. But in the late 80s I wrote a book on anxiety and its disorders, where I was on sabbatical and had a chance to delve deeply into the nature of emotional disorders. I wrote some papers on that 25, 30 years ago. And, it always seemed to me that these disorders really had more in common. They really, what they shared was more important than what differentiated them. And that the classification system had gone too far in creating these little small categories. And that what they shared, in those years, I called it trait anxiety, following the lead of 𝗔𝗹𝗃 back in the 60s. But I also noted in that book I wrote at the time that there were other terms for it. And there was, behavioral inhibition, there was harm avoidance, there was, and of course, the old standby, neuroticism. But it seemed to me they were all really talking about, and negative affect was another term often used. And it seemed to me they were all really talking about the same concept. Each person had a different spin on it. It was the same thing. Say, well, what is this? And then we looked into it more deeply and found that there was a whole literature in the 1940s on producing experimental neurosis in the laboratories, with animals mostly. And they could reliably do it, create these conflicted, extremely anxious animals, you know, who would cower in a corner. And it seemed to have some parallels. They discovered the causes of that. It was instilling a sense of unpredictability and uncontrollability in the animals. They discovered the biological underpinnings of it, particularly having to do with the HPA axis and various brain structures. And this was a common dimension. And even though the term neurosis died, the study of neuroticism continued. And so we picked that up about 6 or 8 years ago and said, maybe we should be focusing on this and treating this rather than each individual disorder.
This common factor here.
This common underlying dimension. And so the unified protocol was an attempt to develop a set of 4 or 5 core elements, along with some other that really attacked the neuroticism directly, the sense of uncontrollability, the emotional avoidance, and the dysregulation of the emotions, which all of these people with all these disorders share. So that was the kind of genesis of that.
That's great. And how do you think that, because this is quite a huge leap to think of the idea that one dimension could be in a way causally related to most of the emotional disorders we know. How do you think this will evolve in the future? Do you think this could have like an impact in all of our interventions? What's the scope of this?
Well, we of course are optimistic about it. We just finished a 5-year clinical trial where the goal was call it an equivalence trial. The goal was to see, is this unified protocol with just the 5 core elements or modules, is it at least as effective as all of our different treatments that we have for panic disorder, for obsessive compulsive disorder, for social anxiety, for depression, for generalized anxiety disorder? You know, is at least as effective as all these different protocols. And the findings basically in one sentence were, yes, it's at least as effective. And in this big trial with hundreds of patients, some of whom got the unified protocol, some of whom got the specific protocols that matched their diagnosis, like OCD, that both groups were very much better than the control group, weightless control group, but the unified protocol was at least as effective and basically equivalent to the individual protocols, and there was less dropout, less attrition. And they found it a very credible and acceptable treatment. So we think this, you know, this is of course one study and it comes from our lab, but we think that, you know, this implies that psychotherapists can take these powerful principles and with one protocol do the work of 8 or 10 different protocols that were so difficult to try and master. You know, the sort of principles, and that it should be more efficient and help in our training and our dissemination.
That's a very interesting line of research, very enthusiastic.
That's of course that's an optimistic assumption, but we think that we're going down that road.
We're drawing to a close here, David, but still I'd like to ask you, in the latest edition of the Oxford Handbook of Clinical Psychology that you edited, the last chapter you make some predictions on the future of the field in terms of training, assessment, treatment. I'd be really curious if you'd like to share some that you think are especially urgent for the future of our field.
Well, yeah, well, you're very well read, I must say.
It's always a pleasure.
I'd have to go back and look at those recommendations myself. I wrote that chapter 3 or 4 years ago, but so I don't remember exactly what I predicted. But I think, in a general sense, we can certainly say that our field is moving forward on a firmer footing, so on an evidentiary footing. We're moving very much towards, evidence-based kinds of practice where we should have been all along. I think schools of psychotherapy are an anachronism. They think of the past. They were kind of pre-scientific, if you like. They served a purpose. But in the face of the evidence, what we're finding is that there were important kinds of procedural contributions from all different branches of psychotherapy. And the evidence is now delineating which principles and elements, are important and effective, and which aren't, and under what conditions for which patients would they be most effective. So I think we're going ahead in this kind of a fashion. I think, as we already discussed, we're integrating important evidence from all branches of science relevant to mental disorders and mental health, psychological well-being, and this kind of integration is going to advance our thinking. It's going to help us to make some great leaps forward. I think the biggest challenges that we have, by far, are the issues of dissemination and implementation. So as psychotherapists, certainly in this country, the United States, we just touch a very small percentage of the people really suffering from the variety of psychological conditions, anxiety, depression. The vast majority of people don't get any treatment whatsoever. The ones that do get treatments often get ineffective treatments, often drug treatments at inappropriate doses or something like that. We now have effective psychological treatments. We know how to do that. We know how to develop new treatments. We know how to evaluate them. We're not always right, and what they will be. But the harder task is really how do we get all these treatments out there to the people who need them?
Yeah.
And this is a very new area, a very new science, the science of dissemination and implementation.
Yeah.
And was our colleagues working in global mental health, doing some very interesting things in third world countries, getting brief, flexible, scalable kinds of psychological interventions out. And they seem to be having some, wonderful results, often working with local health workers, to try to disseminate these treatments. In our own countries, we need similar kinds of efforts. So there's much to be optimistic about. The field is moving forward. It's firmly based on science, but we have many challenges in front of us we're going to have to overcome.
A lot of work ahead of us.
Yep.
I'd like to finish, David, with one last question for you. I have been asking all of our colleagues in these interviews, and that is very simply, after all of your career and all the amazing experiences that you had along the way, I would still be curious to ask you, what advice would you wish to have received when you were starting out your career as a researcher and therapist?
Well, I think I was very fortunate in that I had excellent mentors. And my mentors, by and large, had a very balanced approach to the field. They were both clinicians and clinical scientists, researchers. And so I think by example, what they demonstrated to me was that you should always do both. You should have, this kind of integration of your clinical work and your clinical research. And I always have had that. I think, so I've been very, very fortunate in that. I think my career has unfolded in a very satisfactory way. I'm very blessed to have good colleagues and great resources and strong support. So I, certainly feel like I've been in a very good position. And
so maybe I should ask you what advice you would wish to give to.
So I would think, that the one bit of advice, the one thing that's hard for all of us is kind of striking the appropriate work, non-work balance, balance between work and family. And we all struggle with that. Everybody you talk to, who obviously you talk to some people who've been very successful and very productive, and we all struggle with that. And I think maybe if there had been one bit of more structured advice that I would have gotten, and I think my colleagues might share this, is that there would have been someone who sat down and kind of really worked with us on how do you do this? How do you have both a productive, rewarding career, while at the same time, devoting the attention to other aspects of living, leisure time, your family, your hobbies, your activities that bring balance. And we know that your well-being, your overall well-being depends on that life balance. Our female colleagues struggle particularly with that, because of the pull between the family obligations, they very much devoted to, and the career challenges. Nobody's solved that yet. Nobody's solved that for our very good female colleagues. But for the males, it's the same thing. There are some programs that have little tutorials on this. They have lectures on it. They have maybe a short seminar on it. And I think everybody can benefit from it.
More self-care in a way.
More self-care.
Yeah. David, thank you so much for this opportunity.
Thank you. I'm very impressed with the breadth of how well you're prepared for this.
And
so I enjoyed our conversation.
And I'm extremely happy to have the chance to talk with you. So I hope you continue with your productive work so we can rob it more.
Thank